Yeah, we have 5 speakers today, and the expert panel today will be Dr. Sohan Pereira, Dr. Srinath Illeperma, Anuruddha sir and Neville sir will be listening to you all, and will be asking questions, and we will move on to the discussion. So without delay, we have 5 presenters today to present. So we will start with the first topic, that is urothelial cancer, core topics and evaluation of hematuria. The presenter will be Dr. S. Divika, Senior Registrar. Dr. Divika, over to you. You can start the presentation.
My presentation is going to be on evaluation of hematuria, and also I will be talking about some core topics in urothelial cancer. So as we know, when it comes to evaluation of hematuria, it can be classified into gross hematuria or microscopic hematuria. So if it is a gross hematuria, that means it is naked, is it visible to the naked eye, and it's usually more than 50 red blood cells per high power field. And if it is microscopic hematuria, that means if it is 3 or more than 3 per high power field is called microscopic hematuria. So hematuria can be painful or painless, or it can be associated with other urinary symptoms. And when we in the history we have to ask about the relations to the urinary stream, whether it is present throughout the stream or in the beginning, initial or terminal hematuria, because the differential diagnosis will be different. So that there are so many causes for hematuria. The benign causes come first. So when we are dealing with hematuria, we have to first think about prostatic bleeding, infection, stones. So after the benign causes, there are so many other causes for hematuria. It can be it can be due to the malignancy from upper urinary tract or lower urinary tract. And if there are other, it can be a mixed diagnosis when it is contaminated from the menstrual bleeding or vaginal bleeding. It can be a false hematuria. Or it can be caused by trauma, or it can be also caused by foreign body, or it can be iatrogenic. And there are some other, there are important nephrological causes for hematuria as well, like nephrotic syndrome, glomerular nephritis, and then other syndromic Goodpasture syndrome, HSP, that is common in children, and it can be also caused by drug, or it can be as a part of the systemic manifestation of coagulopathy. So what is the significance? So as we know, the benign causes come higher up, but when we had to always think about the possibility of having malignancy. So when they say if it is a gross hematuria, there's about 10 to 40% of having an underlying malignancy is possible. But if it is microscopic hematuria, up to 5% can be of them can be malignant. How are we going to identify those patients at risk? If we are dealing with a patient, then we have to see whether the patient falls into risk category. So if it is a male patient, if he is above 40, or if it is a female patient above 50, or if the patient is a smoker, or if there's a current smoking history, or if he or she is exposed to the occupational hazards, like the occupations related to rubber, paint, petroleum, or if the patient has any be caused by chronic urinary tract infection, chronic indwelling catheter, neurogenic bladder. So if the patient falls into high risk category, we have to take that patient as a sinister patient, and we have to proceed with further investigations. And so, as I mentioned before, in the history, we had to always ask about other urinary symptoms, special irritative symptoms, or the relations to the urinary stream. And then we had to do the proper examination, starting with DRE to look for, to exclude prostatic carcinoma, and pelvic examination in female, and also genital examination also important because it can be a contaminated sample bleeding from other causes like urethral bleeding, or it can in females can be due to prolapse, pelvic organ prolapse, or atrophic vaginitis. So we have to do a thorough examination. After that, we have to check the patient's blood pressure as well, because it can be if it is a nephrology, if it's from the nephrological cause, the patient can have high blood pressure. And then we had the common cause for bleeding is hematuria as infection. We had to always exclude urinary tract infection by doing UFR and urine culture. Not only that, UFR also, the urine analysis also can reveal further clues to whether there are any proteinuria, whether there are any dysmorphic RBCs, whether there are any RBC cause. So if they are present, that is, they are more suggestive of glomerular bleeding. And then after the initial investigation, we can do a ultrasound scans, KUBP, to exclude, to look for any upper tract or lower tract causes for bleeding. And what about cystoscopy? What is the place of cystoscopy? So according to the NICE guideline and the EUA guideline, for patients with gross hematuria more than 45 years old, there's a place for cystoscopy. So cystoscopy is preferred over cytology because due to its improved sensitivity, because we can directly visualize the bladder. And not only the white light endoscopy, there are other modifications as well. There are the narrowband imaging and photodynamic cystoscopy also available to enhance the diagnosis. And so what is the place of urine cytology? So urine cytology is, yes, there's a place, but that is especially if the cystoscopic, sometimes cystoscopy can miss the carcinoma in situ if we are not carefully looking for. And in carcinoma patients with carcinoma in situ or high grade patient tumor, the cytology can be positive. And what is the place of CT-IVU? CT-IVU is indicated if we are dealing with a young patient, especially if we are suspecting upper tract urethral carcinoma, then we have to go for CT-IVU. Other than that, they say there are some imaging data that suggest combination of ultrasound scan with cystoscopy can be alternative for CT-IVU. So what is to detect the microscopic hematuria? There are two methods available. One is the diptych test, other one is the microscopic examination. So this is about how to do a proper microscopic examination. And then if the microscopic hematuria is present along with the pyuria, we have to always exclude urinary tract infection. So first, if you are suspecting a urinary tract infection, you treat the patient with antibiotics for 6 weeks. Then after that, we can repeat the UFR to see whether it resolves. And other thing we have to keep in mind, if we are dealing with patients who are on anticoagulants, we shouldn't attribute hematuria for anticoagulants medication. We have to follow the same pathway as normal patient. So this is the urine dipstick test. It is basically based on peroxidase-like activity of hemoglobin. So not only hemoglobin, myoglobin also can give the same result. So if the urine dipstick sample is positive, we should always do a proper microscopic examination and confirm. And it can be so false positives can be encountered when there is hemoglobin, myoglobinuria, semen, or high alkalinized urine. And also false negative can be encountered if the patient is treated with vitamin C. And when there's a positive dipstick, we should proceed with microscopic evaluation. At least 46 weeks apart, we have to do 3 microscopic tests. So if the one microscopic test is positive, then we consider it as a microscopic hematuria and then proceed with further evaluation. But if all 3 negatives, if all 3 are negative, then we have to look for other causes which can give rise to false positive. Something about hematuria and pregnancy. So, but hematuria in pregnancy we do encounter. So, it's a special it requires a special consideration. The common causes, as in other patients, we have to always look for whether it's infection, stones, or it can be due to the gynecological bleeding, especially in the early and the latter part of the pregnancy. So again, malignancy in this group, because most are young patients are rare. But if we are suspecting, then we have to evaluate further. And again, occult malignancy can be present in 5% of the cases. And because the problem is we can't do, if we are suspecting malignancy, we can't do, we can't give radiation. Then we have to proceed with MRI, urography or retrograde pyelogram, or we can do ultrasonography if we are suspecting renal lesions till delivery. So after the delivery, if the hematuria persists, then we have to go for proper full evaluation. Again, so this is a diagram about how to start about how to manage the patient, how to manage a patient with gross hematuria. In patients with gross hematuria, we had to look for benign, always the common causes. So if the common cause is identified, if the patient is having low risk for urinary malignancy, then we can discharge and manage the. We don't have to do further evaluation, and we had to manage the benign cause. But if even if there's obvious benign cause, or if the patient is at risk of urinary malignancy, as I mentioned before, if he is a smoker, or if the patient is exposed to the carcinogens or family history of urothelial carcinoma, then we had to further evaluate. And if the cause for hematuria is not found, again we had to proceed with, we have to refer to the urologist, and the urologist will proceed with further evaluation. And if it is a microscopic hematuria, again, no cause found. We have to look for treat the benign causes, and if it resolves, then no need of further workup. But if it is a persistent microscopic hematuria, or if the patient is having the high risk factors, then we have to proceed with the ultrasound scan, cystoscopy, and CTI. But if along with the microscopic hematuria, if the patient is having any clues for renal disease, such as glomerulonephritis, if there are any finding suggestive of glomerulonephritis, that means if the patient is having albuminuria or RBC cast and dysmorphic RBC, then we have to refer the patient to the nephrologist. So what about, even after the complete follow-up workup, if you can't find any nephrological or urological cause, then you should follow up the patient for next 2 years with annual urine analysis and microscopy. Because there's a small risk of having a malignancy is about 1%. If the hematuria still persists over this time, then proper evaluation up to 3 to 5 years further recommended. So this is again from American Urological Association guidelines. This is about how to manage a patient with microscopic hematuria. Again, the same framework. If you can find a benign cause, you manage the benign cause, and then you have to do a proper history. You have to take a proper history and do a proper physical examination. Then they classify the patients into 3 categories. The answer is according to the risk stratification. That means depending on the patient age, depending on whether the male or female patient, depending on the pack years of smoking, depending on the severity or intensity of RBC in high power field, and if depending on whether the patient is having any risk factors for urothelial carcinoma cancer, such as family history or exposure to radiation, exposure to the carcinogens. If there are any risk factors, depending on that, they classify. So they into low risk, intermediate risk, and high risk. If it is a low risk patient, again, you can follow up with only urine analysis. If it is an intermediate risk patient, again, you have to go for cystoscopy and ultrasound scan. If it is high risk patient, then you have to go for cystoscopy with CT urogram. That is about hematuria evaluation. Now I am moving on to the core topics in urothelial cancer. So here I will be discussing about the epidemiology, presentation, risk factors, and the histological subtypes, diagnosis and staging, and also something about risk stratification. Regarding the epidemiology, the urothelial cancer is the second most common urological malignancy in developed world. So, urothelial cancer can be classified into, categorized into lower and upper. Lower when it involves the bladder and urethra, upper if it involves the pelvic LC system and the ureter. Again, bladder cancer is the commonest of two. It accounts for 90 to 95%. Only, but upper tract urothelial carcinoma is about 5 to 10%. The peak incidence it's after 70. And again, are men are men are more than women, and but having said that, because women present late and they present with atypical symptoms, and also they present with advanced malignancy. Therefore, they have aggressive and poor prognostic malignancy. So, when it comes to muscle invasiveness, 2/3 of the upper tract urothelial cancers are muscle invasive at diagnosis, but only 25% of bladder cancers are muscle invasive. And again, in upper tract urothelial cancer, so upper tract urothelial cancer, the pelvic LCL cancers are more common than the other urothelial cancer. It can be multifocal in 10 to 20% of the cases, and concomitant CIS, carcinoma institute, is present in 11 to 30% of the patients. And also there can be concurrent bladder cancer and the upper tract urothelial cancer. It's about 70%, because this is important. When we are dealing with upper tract cancer, we have to always do a preliminary cystoscopy and exclude bladder cancer. And there can be recurrence in the bladder following upper tract urothelial cancer. It's about 29%. And there can be recurrence in the contralateral. It's about 5%. And they say the patients requiring ureteral stenting at the time of TURBT also at risk of developing upper tract cancer. Regarding when the presentation, so presentation depending on whether it's a lower urinary tract or upper urinary tract malignancy, the presentation are different. So it can be a painless hematuria and sometimes irritative symptoms in bladder cancer. In upper tract cancer, it can be incidental most of the time or symptom related when they can present with flank pain or because of the clot or ureteric the tumor involvement. It can cause ureterocolic kind of picture. And they can also have systemic symptoms like anorexia, weight loss, and malaise. If it is present, that is highly suggestive of metastasis. And when it regarding the risk factors, the common risk factors are the smoking and the age of the patient also. So why smoking? Smoking, the smoke, tobacco smoke it's excreted in the urine. So again, that is carcinogenic. And alcohol, and there are something called aristoloic acid that is again produced by this plant. Again, so it has mutagenic properties as well. It can also cause chronic tubular industrial neck disease, and also has high consumption of arsenic in drinking water. And as I already mentioned, the occupational exposure, pelvic radiation, these are the risk factors for bladder malignancy. And schistosomiasis, because it causes chronic inflammation and irritation and squamous cell carcinoma. Again, gender I have mentioned before, men are more likely to develop. And pioglitazone use also can cause bladder CA. So they recommend not to use pioglitazone in patients with bladder cancer. And chronic irritation due to urinary tract calculi or neuro in patients with long-standing indwelling catheters and neurogenic bladder also at risk of developing squamous cell carcinoma. Then coming to the Lynch syndrome. So Lynch syndrome is it's an autosomal dominant syndrome. So hereditary non-polyposis colorectal cancer. Because I'm talking about Lynch syndrome, it is highly associated with urothelial carcinoma, and it can also, as a part of the syndrome, there are colorectal, intramedullary, and other malignancies also present. So it's as we know, it's a mismatch repair mutation. And if we are suspecting to diagnose Lynch syndrome, we have to follow the Amsterdam criteria. We can remember as 3-2-1 rule. Three relatives, two successive generations, and one is the first degree of the other two, or one is less than 50. And having excluded familial erythematous polyposis, and also needs pathological confirmation. So if the patient follows its Amsterdam criteria, we can diagnose Lynch syndrome. This is again, if you are suspecting Lynch syndrome, you can directly proceed with DNA mutation, GM DNA sequencing mutation. But if there's no direct suspicion, again, like screening, like with MMR screening in tumor specimen with PCR or immunohistochemistry is recommended. If that is positive, then go for DNA sampling. And regarding the histology, most of the upper tract malignancies are urothelial. So there can be squamous cell carcinoma, there can be sarcomatous differentiation, or collecting that carcinoma is usually taken under renal cancer rather than upper tract urothelial cancer. Again, bladder cancer also similar subtypes are present. Again, carcinoma in situ is intraepithelial high grade non-invasive urothelial cancer. It can be multifocal, it can be present in blood, prosthetic duct and the urethra. So it can be primary, secondary, concurrent. Primary means it's a new onset with no previous CIS. Secondary in patients with past history of bladder tumor. Concurrent in along with the bladder tumor. So the diagnosis and staging, if we are dealing with the bladder cancer patients, possible bladder cancer patients, or upper tract urothelial cancer, again, initial investigation, ultrasound scan, flexi, again, if you are not sure, if the tumor is not found on ultrasound scan, you can go for flexi. Otherwise, you can directly go for diagnostic TURBT. What's the place of MRI? MRI, again, they say it is better in differentiating T1 and T2. So if you are not planning diagnostic TURBT or diagnostic and therapeutic TURBT, there's a place for MRI. It can give a better idea about the local staging than CT. And what about baseline CT urography? Usually in our practice, we do CT urography after the diagnosed TURBT if it is muscle invasive. But again, there's a place for initial CT urography because there's a small percentage of associated upper tract urothelial carcinoma. It is about 1 to 8%. But if the tumor is in trigone, again it goes up to 7.5%. Again, cytology only in CIS and high-grade patients. There are some commercially available tumor markers also, but not commonly used. So CT urogram is highly sensitive and specific, but the problem is we can miss blood lesions without mass effect, and there's a place for PDG PET also. And if we are dealing with again upper tract urothelial cancer, we have to always combine with cystoscopy and flexible URS. By doing flexible URS, we can visualize the entire tract, especially if we are planning kidney sparing or renal sparing surgery, or it allows for direct visualization as well as the biopsy at the same time. So they say if we are doing URS in upper tract urothelial carcinoma, if we are doing URS alone, there's no significant risk of intravesical insemination or recurrence. But if the URS, if you are combined doing biopsy with during the URS, then there's a small risk of increased intravesical recurrence. And according to the EEA, there is only low-level evidence to use intravesical installation of chemotherapy at that time. Again, so after the diagnosis, as you all know, that TNM staging, again, nearly similar in bladder and urothelial cancer. So for the management purpose, upper tract urethral cancer can be classified into low risk and high risk. Especially the classification, this classification is important to direct our management whether to go for renal sparing surgery or nephrojurectomy. This is the low. You can see the low risk and the high risk classification category. Again, for the non-muscle invasive bladder tumor, there's a risk stratification, low risk, intermediate, and high risk. This again guides us to go for the management purpose and for the follow-up as well. Thank you.
Thank you, Divya, for the comprehensive presentation regarding the core topics and evaluation of hematuria. And now now it's time for discussion. I think we have Neville sir, Amrutha sir, and Sohan Pereira and Srinath in the expert panel. Any questions from the expert panel?
Can you hear me now? Hello?
Yes.
Yes, sir,
Yes.
I can hear.
Yeah.
Yes.
Yeah. Just for the sake of interest, nurses and waiters, what sort of evidence do you have to say that nurses and waiters have higher risk of bladder cancer? Because we are dealing with nurses, and that will be a bit of alarming news for them. Are there any evidence to show that? You mentioned that in your list.
Occupational hazard is there, sir, but the risk is again not that significant, I think.
Yeah, there was only one study showing that if you do 2 shifts instead of 1 shift, there's a higher chance of bladder cancer, but can't think of an etiology, a real reason for that. It applies to waiters too. Others, of course, you can think that those are due to occupational chemicals and things like that. But these two categories, we still don't know the exact cause. And ketamine, did you have any idea about the ketamine cystititis and the relationship of bladder cancer? Is there any evidence to show that ketamine can cause it?
I'm not
There's
sure.
a bit of a discussion about ketamine and the bladder, ketamine bladder, because it's illicit use of ketamine can lead to hemorrhagic cystitis, but there are some DNA and some cytological changes which they have described and may be carcinogenic in the long run. And the cytology, can you just summarize, elaborate on the place of cytology in diagnosing bladder cancers? You mentioned it here and there.
Cytology. Cytology doesn't replace the use of cystoscopy because cystoscopy is highly sensitive. But again, sometimes combining with cytology, we can increase the sensitivity of detecting high grade and carcinoma in situ lesions.
So do you recommend cytology for everybody? I mean, anybody with microscopic hematuria. So whom will you do cytology?
No.
Whom will you do
if
cytology?
The patient is if the patient is exposed to the occupational hazard like carcinogens, if we are suspect again they have high risk of carcinoma in situ. So those patients it can be positive.
So if you see that it has less sensitivity and cystoscopy is mandatory, what's the point of doing it?
Sometimes in cystoscopy we can miss the lesions. So if we are not using narrow band imaging and this photodynamic cystoscopy, sometimes we can miss
is there any evidence to show that? Yeah, that leads to the question: is there any evidence to show that narrowband imaging and photodynamic diagnosis increases the chances of detecting a bladder cancer?
Yes.
What is photo trial? What is the outcome of photo trial? It's 22. So it's keep on coming. So does the outcomes increases the diagnostic value or not? Yeah, the idea,
I'm not sure.
what it says is actually there is no difference. So the place of cytology is actually what? In especially if all the other investigations are negative and still you have hematuria and you can't detect where it is coming from, then there's positive cytology. Then you have to keep on looking for cancers, isn't it? So that is one place. Yeah, so I don't know whether the others also can add to this. So cytology, because we don't do cytology very regularly, or maybe I think we should do more cytology, but exact place of cytology is the question. When to do cytology if it is not routinely done.
So just to start
Yeah.
off with, I think, Tivika, the first question is this term gross hematuria. I don't know whether this is a term that is basically used by urologists, to be quite honest. I think you need to get that out of your head. That can be used by the medics and the non-urologists probably. We can probably, among our colleagues, we can probably say gross hematuria if a person has a lot of soft clots and needs some sort of a bladder washout or something like that. But the main terminology that we use is visible hematuria and non-visible hematuria. We don't even use microscopic hematuria, just to let you know, okay? The other thing is, now, if you had all the, I mean, you have a very cooperative radiologist with not so much of waiting list. You have a patient with hematuria, like visible hematuria. What's the imaging of choice that you would go for?
The first line imaging would be ultrasound scan, then proceed with cystoscopy.
Okay, do you know what the identify study is? So what's the chance of a patient with visible hematuria having upper tract TCC? Is the question. Now, the thing with the ultrasound and the CT, the main difference is that, you know, the CT basically can detect UTUC, whereas the ultrasound can't. So basically, the identify study is what you need to basically read up on, where they have found, still not very high though, I mean, more than 1% chance of detecting a renal cancer or a UTUC in visible hematuria. And the non-visible hematuria, the risk, I mean, the percentage is less than 1% for both. So that's why, I mean, the normal consensus in UK is that, you know, for non-visible hematuria, you do an ultrasound scan. For a visible hematuria, you do a CT urogram. And also in your presentation, you have said that, you know, ultrasound and cystoscopy can basically is equivalent to CT urogram. I don't basically agree with that, because the CT itself can, you know, miss a small flat lesion or even a small TCC, a papillary one even, in the CT urogram. The cystoscopy cannot be replaced. And I agree with Neville's with regard to cytology. There's no consensus in UK as well, to be quite honest about this. I mean, some centers do it routinely, but I don't think most of the centers are doing, to be quite honest, because of its less sensitivity. Although the specificity is very high. I think you also need to know few, I mean, just for the exam point of view, would need to know some urinary biomarkers, but still they have not picked up as yet in practice. With regard to the PDD, the photodynamic diagnosis, there are new studies that basically say that the CIS pickup is higher, and also the risk of recurrence on the long run when you combine it at the time of resection, it basically leads to a reduction of recurrence on the long run, but you have conflicting studies. But the first study basically did not show much of a difference, but there are studies that are basically proponents of that.
Does age, Tvika, last question, maybe from me, does age matters when it comes to the diagnostic algorithm? What is the place of age?
Again, for the cystoscopy cutoff, if it is more than 40, again, we had to go for a cystoscopy. And but again, if we are still highly suspecting bladder cancer without without having fulfilled, we can still go for cystoscopy. But in young patients, the upper tract cancer needs to be excluded. So there's no specific cutoff for a CTI view. Yeah.
Yeah, and what is the EAU recommendation for as the gold standard of diagnosing macroscopic and microscopic hematuria when it's come to imaging? Is it CT or MR? I think Srinath points. So what is the current recommendation? Strong recommendation? Will you straight away go for MRI, or will you get a triple phase CT, CCT with
CT is better
urographic
than
phase?
MRI, sir. CT is better than MRI.
Yeah, I don't know whether Srinath
Yes,
agrees.
Yeah,
We
yes,
still
yes,
go
yes.
for CT, isn't it? Yeah. MRI, I think, still reserved for CT
If there's a
contraindications.
radiation risk
Yeah.
or contrast.
So in the absence of other questions, one question from the expert panel regarding the risk factors in our setups. Does all these occupational risk factors tallies, or is there any other professions or occupations with high risk you observed, or any studies done in our country regarding these risk factors?
Yeah. I think probably Arudha, if he's with us, I think for studies of epidemiology, things like that. Arudha will be the best to answer. Is he with us or not today?
He was with us.
Right. Yeah. Arsenic levels. I can't think of any particular epidemiological study done in our part of the world. If somebody else can, mention it. But even these occupational hazards, we see very rarely. I mean, in my whole lifetime, I would have seen about 3 or 4 people who are exposed to aromatic dyes and aromatic these textile industry and dye masters and other people. And I mean, usually we routinely be asked for the occupation, but apart from smoking is the number one, which is everywhere in the world. Rest of it, I think, occupational hazards wise, I'm not quite sure about it. If anybody else
I've
can.
seen one patient
Yeah.
in their 30s in Kandy, actually, who basically was a painter. And more specifically, what I was just thinking, not evidence basis, he was a spray painter. So whether it has anything to, I mean, rather than just the normal paint, I'm not sure, but I feel that there might be an impact. I'm not sure about that. But painters, definitely there's a risk of these aromatic means.
In the
paint.
peripheries, we see a lot of farmers comes with the bladder tumor, but actually we need to do a study to confirm that, because anyway, farming community, the percentage wise, there is significant farmers. So maybe that is the reason, or unprotected farming chemicals used may be a reason. I think it's time to think for a study on risk factors. Maybe
Yes.
a good idea. In the absence of,
I think agrochemicals and bladder cancer, urothelial cancer is something. Yeah.
okay.
Sure.
So,
Agrochemicals and bladder cancer, the connection, I think young people should investigate this further. Yeah.
okay.
Thank you.
Okay.
Excuse
Thank
me,
you very much.
sir. Chaminda here. Excuse me, sir. Hello.
Yeah,
Chaminda
we
here,
are with
sir.
you. Yeah.
Sir, maybe there's a small practical problem. So if the patient comes with a non-visible hematuria, especially in the pregnancy, with persistent negative cultures, and despite of having normal ultrasound KUB, do we have to further evaluate, or we can safely reassure them?
This is one place where the cytology will come to place, provided she doesn't have risk factors like pelvic radiation or early exposure to cyclophosphamide, and there's a past surgical history of bladder tumors or known bladder tumor. I think once, I think a flexible, I mean, age matters there also. Over 45 people generally, this pregnancy problem doesn't come. So it will be a young patient. So young bladder cancers are pretty uncommon, though we have seen 19-year-old people. So I think repeat UFR is number one. We have to do it, at least 3 samples, and then make sure that there's no proteinuria or associated infection, pyuria. And then, of course, we can observe them after an ultrasound scan. If it doesn't show anything, any obvious masses or hydronephrosis, suspicious hydronephrosis, ureteric and urothelial cancers will not be obvious in ultrasound, but if there will be even mild hydronephrosis, which is common in pregnancy, you have to, I think, follow her with UFR, repeated UFRs and cytology combined during her pregnancy. But anything more than that, I don't know whether it is recommended.
Okay, sir.
Non-visible hematuria.
Yeah. In the absence of questions, I think we have beyond time also. We will move on to the next topic. Dr. B. Pragaladan, Senior Registrar, will be talking about non-muscle invasive bladder cancer for next 15 minutes.
Yeah. So good evening. Today I'm going to talk about the management of non-muscle invasive bladder cancer. So most of the slides are discussed by my initial slides are discussed by my previous topics as well as my expert panel. So as an introduction, is a bladder cancer. It's about 7 diagnosed cancer. It's about 75% of the cancers are the non-muscle invasive. So it can be a carcinoma in situ or the submucous the T1 or TA. So tobacco smoking is the one most important risk factors about the 50% of the cases, and the second most one is the exposure to the aromatic amines. So as a previous speakers discussed about the TNM staging, here I am talking about the management of TA, the non-invasive papillary carcinoma, and the TA is a carcinoma in situ as well as the T1 tumors. The histological grading of non-muscle invasive urothelial cancer, the 2004, the WHO published the histological classification system include the papillary urothelial neoplasm of the low malignant potential and the non-invasive papillary carcinoma with the low grade and the high grade. The carcinoma in situ and its classifications, the carcinoma in situ is the intraepithelial high grade non-invasive urothelial cancer. So it can be missed or misinterpreted as inflammatory lesions during the cystoscopy, if not biopsy. So the carcinoma in situ is often multifocal and can occur in the bladder, but also in the upper tract as well as the prostatic ducts and urethra. So it can be classified as a primary, where there are no previous or concurrent papillary tumors or no previous carcinoma in situ. The secondary, where the follow-up patients with the previous tumor that was not the carcinoma in situ. And the concurrent with the associated with other urothelial tumor in the bladder. The subtypes of urothelial cancer is about more than 90% of the cases is the urothelial carcinoma. Other subtypes here, these are very important because other subtypes of urothelial carcinoma is all considered as a very high risk group in the risk stratifications, such as the urothelial carcinoma with the partial squamous or glandular divergent differentiation, the micropapillary urothelial carcinoma, nested or microcystic variant, large nested variant, microtubular urothelial cancer, plasmacystoid signature, and the lymphoepithelioma like urothelial cancer, the GN cell diffusion undifferentiated sarcomoid urothelial cancer, and the urothelial carcinoma with the partial or pure neuroendocrine carcinomas. My previous speakers discussed about the diagnosis and about the journal cytology. The high sensitivity in the high grade and the regarding the journal cytology, it's having a high sensitivity in the high grade and as well as G3 tumors. It's about 84%, but the low sensitivity in the low grade and the G1 tumors. The sensitivity in carcinoma detection is about the 28 to 100%. So about to perform the cytology on at least 25 ml of fresh urine or urine with adequate fixations. The first morning sample is not suitable because it's causing the tumor lysis. So, regarding the cystoscopy, our expert panel discussed about that new methods of tumor visualization. That regarding the photodynamic diagnosis, that using ultraviolet after the intravesical installation of 5-amino-levulinic acid or the hexamino-levulinic acid. Study says the more sensitive than the conventional procedure for the detection of malignant tumors, particularly for the carcinoma in situ. So TURBT for the TA T1 bladder tumors. The goal of TURB in a T1, TA or T1 bladder cancer is an accurate pathological diagnosis, the staging, and completely remove all the visible lesion. So either it can be done by the either fractionated or the en-bloc techniques. So the en-bloc provides a high quality resected specimen with the presence of dead tissue muscles about 96 to 100% of the cases. But it's practically for the small tumors, it can be possible. The absence of dead tissue muscles in the specimen, the high risk of residual disease, early recurrence, and the tumor understaging. So regarding the bipolar and the monopolar resections, the study says that bipolar resections having a reduce the risk of complications such as the bladder perforation due to the operator nerve stimulation and to produce the better specimen. And we can combine the TURB and the TURBP because it studies says that there is no increased risk of tumor recurrence or progression. So regarding the endoscopy biopsy, it's a bladder biopsy. So we need to consider about that in a carcinoma in situ. So because carcinoma in situ in the cystoscopy appears as a velvet-like reddish and indistinguished from the inflammation, or it may not be visible at all. So biopsy from the suspicious urothelium should be taken. Where the urine cytology was positive, so we can if there is abnormally mucosa not detected, so we can go for a mapping biopsies from the bladder. So regarding the prostatic urethral biopsy, so involvement of prostatic urethra and the duct in the men with the non-muscle invasive bladder cancer has been reported. So the risk is high, the tumor is located in the trigone and the presence of bladder carcinoma in situ and the multiple tumor. So we can take it from the precollicular area, that is from the between the 5 to 7 o'clock position with the resect group. So regarding the second TURBT, so because there is a significant risk of residual tumor after the initial TURBT for the T1, TA and the T1 has been demonstrated. So the second TURB, which increases recurrence-free survival as well as improves outcome after the BCG treatment and provides the prognostic information. So performing a second TURBT after incomplete initial resection or whether doubtness of completion of TURB, or if there is no dead tissue muscles in the specimen or in the T1 tumors. So the EAU recommends the second TURBT for in 2 to 6 weeks after the initial resection. So this is regarding the TURBT checklist. So while doing a cystoscopy, we need to systematically document about the urethra as well as prostate and the ureteric orifices, if any presence of diverticuli or any tumors within the diverticuli. Regarding the tumor, its location, number, size, and the appearance and any evidence of carcinoma in situ. And the method of for any light source as well as regarding the urine for cytology of the bladder wash. With the TURBT, we need to document about that resection technique as a en-bloc or the fractionated and the depth of the resection and the complete or incomplete resection. If we done the prostatic urethra biopsy or not, and any additional procedures such as any stenting has done, and these things we need to mention about. So the patient stratification into the risk groups is based on this, the patient the management will differs. We can divide it into the low risk groups where it having a TA or T1 with the low grade tumors, and it also having there are additional risk factors such as the patient's age more than 70 years and the tumor size more than 3 centimeter and the multifocality. So in the low risk considered as a primary single TA-T1 low grade tumor with less than 3 centimeter without carcinoma in situ in patient with less than 70 years. Or the primary TA low grade tumor without carcinoma in situ with the most one of the additional clinical risk factors as I mentioned earlier. So the very high risk group is considered as a all T1 high grade without carcinoma in situ except those included the very high risk group. All carcinoma in situ patients except those included in the very high risk group. So the very high risk group is the TA high grade and the carcinoma in situ with all 3 risk factors, and the TA T1 G2 and the carcinoma in situ with at least 2 risk factors, and the T1 high grade G3 and the carcinoma in situ with at least 1 risk factors. T1 with the high grade, no carcinoma in situ with all 3 risk factors. Others are considered as an intermediate risk. I already mentioned about the additional clinical risk factors, age more than 70, and the multiple papillary tumors, and the tumor diameter is more than 3 centimeter. And all patients with a carcinoma incident in the prostatic urethra with the subtypes of urothelial carcinoma or with the lymphovascular invasion should be included in the very high risk group. So the patient with the recurrent tumor should be included in the intermediate, high or very high risk group according to the other prognostic factors. The probability of disease progression according to the risk groups category. So for the low risk group, is a 1 year recurrence is very low, it's 0.6%. At the 5 years, it's about less than 1%. At the 10 years, it's about 3.7%. For the intermediate, it's a 1 year about 1, and the 5 years at 5%, and the 10 years about 8.5. For the the high group, it's about 1 year about 3.5, and about the 5 years about 10%, and at 10 years, it's about 14%. For the very high group, it's very high percentage. In the 1 year, it's about 16%, and the 5 years about 40%, and the 10 years about 53% chance of the progression of the disease. So management, so generally we need to counsel about the smoking if the patients are smokers. So we can the management options are there. We can consider the adjuvant intravesical treatment. So although TURB is itself can eradicate the Ta/T1 tumors, so but these can progress as well as recurrence to the muscle invasive bladder cancer. So regarding the intravesical chemotherapy, so the immediate single installations, it can act as destroying the circulating tumor cells after the TURB. So after a single installation, its evidence says it's reduced the 5-year recurrence rate from 60% to the 14%. So we can use the single installation with the mitomycin, epirubicin, or the prerubicin gemcitabine. So it's shown to lower the intravesical recurrence rate. To maximize the efficacy of single installation, we need to give it as soon as possible after the TURBT, preferably within the first 2 hours in the recovery room or even in the operating theater. So in one study, there are some studies says there's a further chemotherapy installation after the single installation improve the recurrent-free survival in intermediate risk patients. But regarding the length and the frequency of repeat chemotherapy installation is still controversial. So however, it should not exceed 1 year. So regarding the intravesical VCG, so there are meta-analysis confirmed that the VCG after the TURB TURBT alone or the TURB plus chemotherapy for preventing the recurrence of non-muscle invasive bladder cancer. The Hogren systematic review confirmed that the VCG is more effective in reducing the recurrence rate over mitomycin C. Regarding the toxicity, it can lead to local toxicities as well as systemic. Locally, it can cause the cystitis, hematuria, prostatitis, and epidermolysis. As systemically, it can cause the fever, arthralgia, BCG, sepsis, and allergy. So, but it's having the most side effects compared to the intravesical chemotherapy. The serious side effects are encountered in less than 5% and can be treated effectively in almost all the cases. So, incidence of BCG infection after the BCG installation was less than 1%. The side effects of recurring the treatment stoppage was seen in more usually within the first year of therapy. So regarding the optimal number of induction, so the induction BCG installation, so given empirically for weekly for 6 cycles schedule introduced by the Morales et al. And for the optimal efficacy, so the BCG must be given in a maintenance schedule. So the usually standard one is a 6 installation in an induction, and then the 3 installation for a maintenance at 3, 6, and the 12 months. Regarding the optimal dose of BCG, to reduce the BCG toxicity, the installation of a reduced dose was proposed, which suggested that the full dose of BCG is more effective in multifocal tumors, and the 1/3 of the standard dose of BCG might be the minimum effective dose for the intermediate risk tumors. So there are some studies regarding the combination therapy. The combination of MMC and the BCG says the more effective in reducing the risk of disease recurrence while increasing the toxicity. Where the patient with the BCG unresponsive disease, when the treatment standard radical cystectomy is not feasible due to the age or the comorbidities of patient not willing, we can consider this sequential installation with the gemcitabine, docetaxel is an emerging treatment concept. So other options are we can consider the radical cystectomy for the non-muscle invasive bladder cancer. It's a reasonable to propose the immediate radical cystectomy in those patients with the non-muscle invasive bladder cancer who are at the very high risk of disease progression. For the early radical cystectomy is strongly recommended in patients with the BCG unresponsive tumors and should be considered in a BCG relapsing high-grade tumors. So in patients whom underwent the radical cystectomy before progression to the muscle invasive, the 5-year disease-free rate exceeds more than 80%. So as a summary, so the primary treatment by the disease type for the treatment of low-risk disease, it's having a negligible risk of disease progression. So the single installation of chemotherapy reduces the risk of recurrence and is considered as a sufficient treatment after the TRBT. For the treatment of intermediate risk disease, it's a low risk of disease progression is about 8% after 10 years. So the EAU recommend the 1 year full dose of BCG treatment. So induction plus 3 weekly, installation at 3, 6, and the 12 months for the maintenance, or installation of chemotherapy for a maximum 1 year is recommended. For the treatment of high-risk disease, it's having high risk of disease progression is about 15% after 10 years. So the full dose of intravesical BCG for 1 to 3 years. So the additional beneficial effect in the 2nd or 3rd years of maintenance would be weighed against the added cost as well as side effects and the BCG shortage. So immediate radical cystectomy may also be discussed with the patient. So the treatment of very high risk group is extremely high risk of tumor progression, about the 50% at the 10 years. So the immediate radical cystectomy should be discussed. In case of radical cystectomy is not possible or the refused by the patient, we can consider the full dose of intravesical BCG to 1 to 3 years. The treatment of carcinoma in situ is endoscopy procedures alone is not enough. So the BCG treatment of carcinoma in situ increase the complete response rates, the overall percentage of patients who remain disease-free, and reduce the risk of tumor progression. So the immediate radical cystectomy for the carcinoma in situ results in excellent tumor-specific survival rates. So recurrence during or after the intravesical chemotherapy, the patient with the non-muscle invasive bladder cancer recurrences during or after the chemotherapy regimes can benefit from the BCG installation. Prior intravesical chemotherapy has no impact on the effect of BCG installation. So the treatment failure after the intravesical BCG, the patient with the BCG unresponsive disease are unlikely to respond to further BCG therapy. So we need to consider about the radical cystectomy. So this is a summary of this BCG failure. So that we can be BCG refractory tumors or BCG relapsing tumors or BCG unresponsive tumor and the BCG intolerance. The treatment option for the various categories of BCG failure, the BCG for the BCG unresponsiveness, we can consider the radical cystectomy. The late BCG relapse, we can consider the radical cystectomy. And the low-grade recurrence after the BCG for primary intermediate risk, we can consider the repeat BCG or intravesical chemotherapy. We can consider the radical cystectomy. So regarding the follow-up, the low-risk tumors, we can consider the cystoscopy at 3 months, then after 6 months, then yearly for 5 years. For the high risk and the very high risk tumors, the cystoscopy and the urinary cytology at 3 months, every 3 monthly for a period of 2 years, then 6 monthly until the 5 years, then yearly. So the intermediate risk group should be in between these follow-up scheme using the cystoscopy. So the yearly upper tract imaging we need to consider for a high risk and the very high risk tumors.
Okay, thank you, Dr. Pragalad. I think you have stick to the time, and I think you have did the most of the management regarding the non-muscle invasive bladder cancer. So we'll move on to the discussion regarding comments and further questions regarding non-muscle invasive bladder cancer. I think Neville sir and Srinath sir and Anuruddha sir is here.
Yeah. Regarding the BCG therapy, how many doses of BCG is generally given?
So
in one course, how many doses?
So induction, so we need to give for 6 cycles for a weekly, sir. Then the maintenance.
If you count it, how many? How many courses are there?
I think 28 or something.
27.
27.
Are there any studies to show that by reducing the frequency or the dose of BCG will make a difference?
I am not sure about the studies names. I think Nimbus or something. So when we can consider the giving a 1/3 of dose to reduce the shortage of to reduce the side effects, but it's not affecting the progression, disease progression, or any cancer management.
Yeah, I mean, if you compare intracycle chemo and BCG, what is the difference?
So the BCG, it can.
If you are given an option to select.
Yes, BCG,
what
we can
select?
prevent the disease progression as well as the recurrence. But the intravesical chemo is mainly reduce the recurrence.
Yeah, the disease progression will not be affected if you give intravesical chemo, isn't it?
Yes.
Right. And does this apply across the board to all the superficial bladder cancers? This BCG preventing disease-free survival or disease-free and progression-free survival, does it increase in all the superficial bladder cancers? Are there any studies to show that? Despite the, yeah?
So,
yeah, actually, have you heard about, what is Sylvester trials? You know, Sylvester Institute has done many trials on these, on BCG. So you should know about Sylvester's. There are about 4 or 5 trials and large number of patients, Sylvester trials. And that has shown that this disease progression and disease-free survival is increased only for low risk and intermediate risk. When it comes to high risk and high grade bladder tumors, this advantage is actually not very obvious. So that's why they are pressing for cystectomy. Cystectomy rather than going for repeated dose of BCG or BCG. So so this advantage is more pronounced in low grade and intermediate grade bladder tumors. And that brings us, what sort of a grading system is now acceptable? What do we follow? Bladder grade system grading? Just a simple, I mean, this was mentioned in your lecture.
Yeah, WHO 2020, 2014 to 16.
Yeah, make up your mind. Is 14, 16 or 17?
14.
All right. 17, WHO 17, and what is the new grading system now introduced recently? Yeah. 22, EAU has introduced the 2022 grading system, the new grading system, and now actually a lot of people go. Now in your lecture, you mentioned about the hybrid system, where G word, that is ASH classification earlier, G is also there, and then there is this classification of PUN lump. What is PUN lump? With a new classification, has the PUN lump and urothelial cancer with low malignant potential and urothelial cancer with high malignant potential. So that's how you classify. And the earlier one, 2017 WHO, it is G1, G2, G3 ASH grading. And they now, of course, they follow a hybrid classification. On that, only now the risk classification is made. In your chart, you have mentioned that. So do you do in your practice, do you do this risk classification in all bladder cancers you come across?
It's a practically we are not doing the all the risk classifications. We are.
Why not? I think you are supposed to. Yeah. What is the problem? I mean, a lot of urologists are not doing it. But easy way out, there's a risk calculator. Calculate, if you, the website is given, yes. If you go to risk calculator and add all your risk factors into that, it will give straight away whether it's a high risk, low risk, or very high risk, things like that. So you don't have to keep on, memorizing things.
Okay.
So I think my advice is, I think in future, all bladder cancers, try to classify into these risk groups. Otherwise, in future studies, in our local studies, it's going to affect us. So studies will not be accepted. So yeah, that's one thing. Anything else, Srinath? And Sohan is also there? Yes.
I think so and so is not there, sir. We'll
Not there, is it? Okay. Have you
So
heard about, what I
No,
I
I'm
saw him
here.
move? Yeah, he's here. I saw him moving around. Can't miss him, no.
Sohan is around and
No,
he's changing
all
clothes
right.
as well.
He has gone to put his tie on, I think.
Still working, sir.
Right.
Still working.
Yeah, good. You have any questions, Susan? And what is your idea, Pragladan, about putting, say, intravesical chemotherapy after nephrourectomy? Is it recommended or not? You do a good nephrourectomy, bilateral or unilateral, and is there any recommendation to do chemo prevention of recurring bladder tumor?
So I think so that
Because
there is a risk of developing the bladder cancers about 30% in the upper tract urothelial cancers. So we can, if we are going for a single
True.
installation of, will reduce.
Yeah. Is there any evidence to show that it is doing anything good?
Low level evidence is there, Neeraj.
Yeah. What is the trial involved in that? POUT trial. You read about POUT, and it shows that after nephrourectomy, whether to do surveillance, just observe it. Of course, you have to exclude carcinoma in situ in all nephrourectomies, because as you said, 25 to 30% of having carcinoma in situ or bladder recurrence. So you do a good cystoscopy before anything, and then any suspicion, you take what do you call mapping biopsies. What is mapping biopsy? Bladder mapping biopsies. This is a standard word.
Yes, sir. So we need to do the systematic biopsies from the all the areas to cover the.
Yeah, all the area. What do you mean by all areas?
So we need to take it from the
Because you are doing it practically, so.
Yes. So
Bladder
it's
neck, yeah.
bladder neck, then the trigonal area.
How many biopsies are involved in a mapping biopsy? Roughly. If you tell the areas, even doesn't matter.
I think 7 or 8 we need to take it from. So we need to take in the bladder neck, the trigonal area, and
even number. Yeah, there are two sides to the bladder. So even number. You say 7, you are missing one side. And okay, that is the side walls, and then anterior wall, and then trigone, as you said. Yeah. And when you decide to do a prosthetic biopsy, you mentioned that. Can you recapitulate it?
Yes, sir. That
when you decide to do a prosthetic biopsy.
Tumors are involved in the bladder neck or the trigonal area. We need to consider about that.
Yes.
Or the patient with any evidence of carcinoma in situ.
Okay, yeah. So that has to be done. But this POUT trial shows that if there is any advantage of putting chemotherapy after nephrourectomy. That was my initial question. Whether this is useful or not, they have done this comparative study. And actually, there is a slight advantage in doing that. But I think it has not reached the significant levels. So I don't know, in our practice, we are doing it. I don't know whether Srinath, that part of the world, they do it after nephrourectomy, routinely putting intravesical chemo.
When we were doing nephews here, this was not the practice, but now it's become the practice, because now, I disagree with Tirka. Now there is enough evidence to say it's the ODMIT-C trial that has said that, the risk of recurrence is very low. So you need to give mitomycin. So it's a routine practice. Okay. And the next question I'm going to ask, okay, if you are going to give mitomycin, when are you going to give it?
So
after nephew, you've done a nephew, successful nephew. Now the patient, you've stitched up the skin and you put the catheters in. And the theater nurse says, oh yes, we have mitomycin in the theater as well.
So within the first 2 hours, so we can do even the theater or in the recovery room, we can give it.
Depends on how the lower end is taken. If it's a rip and plug technique, definitely no is the answer, because there's going to be a hole in the bladder, obviously, and you let the catheter let sort it out. But if now the rip and pluck is also now going out of fashion, now with the robotics and things like that coming, they suture it, but still they don't give the mitomycin after surgery. So that's something that you need to, I mean, these lectures are targeted for exams. I know these are not practical things for you, but they say that at the time of talk, it's best to give it. So if you have decided to do a talk in 1 week or 2 weeks, best to give the mitomycin at that time before the catheter is taken out. That is decided by the surgeon, depending on, whether the technique that was followed for the bladder cuff excision. So never given at the time of surgery, because mitomycin, if it leaks into the pelvis, it causes a condition called the mitomycin pelvis, like a frozen pelvis situation, and it's a very, very difficult condition to treat. So that's why even after a URBT, if there's a slightest suspicion of a bladder perforation or a thinned out bladder wall, it's always best not to give it rather than to give it.
Srinath, what is the
totally,
temples?
Yes, please.
So this now temples we are practicing.
Sorry, Zohan.
Hello. Now this temples technique, Srinath, now are they doing it in UK? When I was there, they were not happy with the temples technique. This rip and plucking thing, what you were talking about?
Yeah. Rip and pluck is, I mean, not a no apparently, but now increasingly, I am not in a place where robots are present anyway. Now the nephews, they use the robot, they use everything. Now I think the circumcision is the only surgery that they don't use the robot so far. So, I mean, it's come to an insane situation like that. Because the robot is used, they always stitch the bladder properly. I mean, that's what they say. I've not seen it or anything like that. So, the rip and pluck is basically going out of fashion, but in places where laparoscopy is used for nephew, of course, the rip and pluck is still used.
Yeah, the principle of this simple technique or rip and pluck is that the lymphatics are shared with the deep trigone and the low end of the ureter. So if you have mid-ureteric or low ureteric, especially your low ureteric carcinoma, the longitudinal spread can involve the deep trigone. So taking the little cuff from the bladder was it was the fashion, but it was never proved with evidence that there is a higher chance of recurrence at the site of ureteric removal. So there was no comparative trials or anything. So that may be the reason why this type of endoscopic resection and plucking the tumor, the ureter from top, or taking the bladder cuff. I mean, that was a very standard surgery for a long, long period, and that is not being practiced by some people. Not in the guidelines. It was not emphasized on guidelines either now. But I agree with Srinath. I mean, the practices change all the time. But taking the bladder cuff, better to know the principle of it, doing it. So, especially in the low ureters, the tumor is there in the low ureter.
I will end up with just one thing about narrowband imaging. I will not talk. I will not tell the answer as well. This is probably a question for an exam, I would say. What is narrowband imaging, and I mean the technology involved in that. It's either a question in the bladder cancer bay, or it could be a question in the technology bay. I think I would leave that to the candidates to find out. And that's it. We need to move on, isn't it?
I think we move on to the next topic. We have a lot of questions, but we don't have much time to discuss all the things. So next topic is muscle invasive bladder cancer, which is done by the Dr. Madhushankar, Senior Registrar, Urology. Over to you, Madhushankar. You have 15 minutes.
Muscle invasive bladder cancer. Directly, I will go into my topic. Regarding the staging and the surgical management of the muscle invasive bladder cancer. Here I will be discuss about the localized disease, that is PT2 to locally advanced disease, T4A. We consider the detrusor muscularis propria involvement as the muscle invasive bladder cancer. And at the initial presentations of the bladder cancer, the 20 to 30% patient present with muscle invasive disease. And remainder that non-muscle invasive disease, about 25% of the remainder may progress into the muscle invasive disease at later. And the problem here with the muscle invasive disease is if we untreated, it has very poor survival rate, that is 3% of 5-year survival. And majority, 90% of them are urothelial cancer. And it has complex and multidisciplinary approach in the when we treat. Regarding bit of diagnosis, it has multimodal approach. Initial TURBT is the gold standard, with the bimanual examination, the physical examination to see the any extra vesicle involvement. And it combined with the adjuvant role, that's adjuvant role with the cross-sectional imaging. And this is as my co-star discussed regarding the PNMA classification, that is 2017. I won't be discuss much here. And regarding the management, I'll discuss about the imaging. CTs, regarding the imaging, the cross-sectional imaging with the CT, it has high spatial resolution, the short acquisition time, and wider coverage in a single bed hold, and there is accuracy of 60 to 80% of accuracy. And regarding the local staging, there is MRI has superior MRI is superior when compared to CT with the soft tissue contrast resolution, and it has accuracy of 70 to 96%. When comes to TA to T3A tumor, CT is unable to differentiate between stages. And CT is useful for detection of the invasion into the perivesical pad and adjacent organ. When it comes to lymph node metastasis, we consider the pathological node. The size is more than 8 millimeter for the pelvic nodes and more than 10 millimeter for the abdominal nodes with the short axis diameter. And when it comes to the distant metastasis, the computer tomography and MRI are equivalent in the diagnostic technique. And for the lung metastasis, CT scans are better, but the liver metastasis, the MRI is better. When it comes to the PET CT, there is evidence of the PET CT for muscle invasive disease still limited, but there is a place when prior to radical treatment in locally advanced disease. I'll discuss about the treatment here. The mainstay of treatment will be the radical cystectomy with pelvic lymph node dissection plus urinary diversion. And regarding the lymph node dissection, I will be discussing in my future slide. There are 3 stages of lymph node dissection: the standard, extended, and super extended lymph node dissection. When it comes to the radical cystectomy in men, the prostate vesicles in routine, and in women, anterior pelvic extension is often used. Regarding the pelvic lymph node dissection, the bladder has complex lymphatic drainage, and the lymph node dissection up to the mid-upper third of the common iliac vessels they are usually common iliac vessels are usually done, and there is no additional benefit with the super extended lymph node dissection. These are the lymph node dissection level. The extent of the lymph node dissection level, as I mentioned, that is not very established up to date. And standard lymphadenectomy is the involvement, the removal of nodes cranially up to the common iliac bifurcation, with the ureter being the medial border, and including the internal iliac, presacral, and the obturator fossa and the external iliac node. That is called extended lymph node dissection. And in high volume center trials, they have not seen any superiority between the extended and the super extended, that is up to the superior mesenteric artery level lymph node dissection. These are diagrammatic representation. Here, the circle one is the standard practice, that is extended pelvic lymph node dissection. The involvement, the genitourinary nerve and the pelvic side walls laterally, the circumflex iliac vein, the Crockett's node distally, and the obturator fossa with the full exposure of the intrapelvic course of the obturator nerve, that is called triangle of Maselli, and posteriorly and the internal iliac vessel posterolaterally, and the internal iliac vessel posteriorly, including the tissue medial to the those vessels. And the template proximally ends at the mid-upper third of the common iliac vessel. These are the flow charts of the management. And the radical regarding the radical cystectomy, these are the other common indications. As I mentioned, that the T2 to T4 disease without distant metastasis, and other indications are high risk recurrent superficial tumors. As by my co-SR discussed, the BCG resistant disease, the extensive papillary disease that cannot be controlled with the primary therapy, and a salvage cystectomy is the bladder preservation phase, and the T4 disease as a palliative option. And the place for the urethrectomy. If the tumor is located on the trigone or the bladder neck with a concomitant bladder CIS, and in case of multiple bladder tumors, and the involvement of the posterior urethra, we can determine at the time of the primary TURBT or by Prosson section during the cystoprostatectomy procedure. Regarding motility and the morbidity of the radical cystectomy. In high volume centers, there are mortality ranging from the 0.8 to 8%, and there are other complications such as renal and pouch stones, incisional hernia, the anastomotic strictures, recurrent UTIs, and the acidosis and uremia in dialysis, the nocturnal stress and urge incontinence in 50% of the cases, and most of the time erectile dysfunction and erectile dysfunction post-operative. And the urinary diversion, I will not be discussing in the urinary diversion in this part of my lecture because it's beyond my scope here. And the main urinary diversion techniques are the ileal conduit, orthoptic bladder, and the catheterizable pouches, ureterosigmoidostomies, and in rarely the cutaneous ureterostomy. Regarding neoadjuvant chemotherapy, the bladder cancers, the muscle invasive bladder cancers has sensitivity to cisplatin-based combination chemotherapy, and there are random RCTs. They have demonstrated the clinically relevant and statistically significant survival advantage with the MIBC with platinum-based neoadjuvant chemotherapy prior to radical cystectomy. They have shown that 5 to 7% of improved survival with the neoadjuvant chemotherapy in MIBC. These are the pros and cons of chemotherapy. As I mentioned, the 5 to 8% of improvement of oral survival, and it reduces the burden of the micrometastatic disease prior to the radical cystectomy, and it reduces it improves the survival. Then it has preoperatively they have more tolerability for the chemotherapy, and it achieve the good favorable pathological state with the negative surgical margin. And their disadvantages are this neoadjuvant treatment may delay the cystectomy, and it compromises the final outcome. As we all know that there is a 90-day rule that with the diagnosis, we have to go for the radical cystectomy within 90 days of the initial diagnosis. And other bladder preserving therapies like trimodal therapy, they are the maximal TURBT, radiation therapy, and concurrent chemotherapy. The patients who are not candidates for radical cystectomy and those are not willing, and they are who decide to preserve their native bladder, there's a place for trimodal therapy, and it has 5 years cancer-specific survival of 50 to 80, overall survival from 36 to 70. And other bladder sparing approaches are the radical TURBT for the selected patients with small bladder tumors less than T1B, clinical stage less than T2, and without carcinoma in situ, and the tumor amenable to deep resection, such as and without and other thing is the tumors not present on the dome and the high posterior wall. And there is a small place for partial cystectomy. It's as an alternative option. Patient with similar tumor characteristics with the exception of the dome and the posterior wall. Those are ideal locations for the partial cystectomy. And regarding surveillance, sorry for the small print, I'll elaborate on them. The patients treated with cystectomy need to be followed up with the laboratory evaluations such as urine cytology, liver, renal function test every 3 monthly for the first year and every 6 monthly for the second and third years and annually. And other metabolic abnormalities with the urinary diversion, electrolyte abnormalities, acidosis, and the features of obstructive uropathic chronic kidney disease, they need to be followed up, and also the osteopenia and osteoporosis and vitamin B12 deficiencies following the radical surgery. And for the cancer surveillance, CT imaging, CT chest, abdomen, and pelvis, every 6 monthly for the first 3 years, then annually for up to 5 years, and only after clinically indicated thereafter. And patients who receive bladder preserving surgery such as trimodal therapy require careful surveillance following therapy for the evidence of local recurrence and the detection of newly onset urothelial CA. And regarding the studies related to the muscle invasive bladder cancer, the robotic cystectomy versus open surgery, and it's non-inferior when it comes to it's non-inferior when compared to the cancer-specific details, but it has benefits of non-invasive, minimally invasive surgeries, but with the advent of high cost. And the prognostic markers, the main prognostic marker of the MIBC are the tumor stage and the lymph node stage. And lymphovascular invasion, when present, 35% of the patients correlated with the 1.5-fold risk of recurrence and cancer-specific mortality. And tumor location has been associated with the prognosis such as bladder, neck, and trigone tumors, and prostatic urethral involvement also associated with worse survival outcome. That will be the end of my lecture. Thank you for hearing. Thank you.
Thank you for that excellent presentation, Madhushanga. And now the topic is open for questions and comments from the expert panel.
I think you have covered most of it. Srinath has any questions? So,
Madhushanga, excellent presentation. I think you basically placed a lot of emphasis on neoadjuvant chemotherapy, which is basically the gold standard. I don't know whether it's now happening. I mean, it's always not in everyone, obviously, but in very, youngish, fit patients, it's always best to have a conversation with the oncologist to have some neoadjuvant treatment, chemotherapy before cystectomy. It's been very well proven. I'll just finish off with one thing. I'm pretty sure I think Neville sir will not agree with this. This trimodal therapy, whether we like it or not, is picking up quite significantly. There's a study 2 months back. You just have to read that up. It's in BJUI, which basically compares it with radical cystectomy. And I think you mentioned that in your lecture as well, Madhushanga, it's been proven to be, superior in all the, statistical analysis in overall survival, cancer-free survival, and everything. So, these kind of, new changes are coming. So it's best to know about it. One last question. This is just not a theoretical question. These are things that are happening now. Madhushanga, now, is there a place for a patient to go straight towards radical cystectomy without a TURBT? Just imagine you are in utopia. Utopia is you have everything under the sun, everything, FDG, PET, you name it, and anything is there. You have all the facilities, and then you have a patient You've done a flexible cystoscopy for him. And then all of a sudden you say, you know, okay, you will consider this patient for a cystectomy without TURB. How is that happening? How is that going to happen?
Sorry, sir, I can't think of it.
Will you do it?
These are relatively new information. I know this because you covered most of the things. I'll just tell you the small print things. Now they say that if on flexible cystoscopy, it's very much, you are in concordance with a muscle invasive bladder cancer. You can take a flexi biopsy and you need to do an MRI. So this is the place where for UTUC, the urothelial carcinomas, MRI comes into place. And you do an MRI just to see mainly the muscle invasion, which can be reliably found out in the MRI. So you have this classification, like the pirates, you must have read about it now, called VIRADS, VIRADS. And then that flexi biopsy and the MRI is sufficient for you to go straight to cystectomy. In places like here, basically they have found that the time that the patient has a cystectomy, is reduced compared to a patient who has a TURBT, because we have lots of things, that need to happen, MDT and all these things. I know these logistic delays are not there in Sri Lanka, but so that is also the new thing in the market, where just a flexi biopsy, MRI, and then straight to cystectomy. That's called the bladder path study. You want to read.
Madhushankar, one thing you touched about partial cystectomy.
Yes, sir.
Hello, I think something went
Can
wrong.
we can
Yes,
hear
sir.
you?
I can hear you, sir.
Go ahead.
Yeah. So now partial cystectomy, what is the place what is the place of partial cystectomy in adenocarcinoma? When you get a urachal remnant, you go for radical or you think of partial?
So in adenocarcinoma, the partial cystectomy has a place, but in UCC, there is no place, I think.
But in adenocarcinoma, some guidelines say to go for radical cystectomy, but most of the patients don't like that.
I think I have a different opinion. If the primary adenocarcinoma of bladder, we have to do the cystectomy, but adenocarcinoma origin from the urachal remnant, I think we can do the partial.
Yes.
Okay. Yeah, I think adenocarcinoma is a different ball game. I think still urachal or primary adenocarcinoma de novo, best treatment will be radical cystectomy. I will be very conservative about that, about doing a partial on that. But a person who doesn't like to go ahead with radical cystectomy or diversion, if the recurrences are coming in same place in the dome, where you can resect it and then suture it easily, not in the base. There is a place, not evidence-based studies are there, that laparoscopic or open partial cystectomy has a place. But I think it will be a very limited number of patients. Time permits, one thing that this trimodal therapy is coming up in a big way now is that in developed countries, the bladder cancer pickup rate is very high. I mean, with every microscopic hematuria, they will do a dipstick or a full one-step hematuria clinic. They will pick up at an early stage and small volume bladder cancers. So when it comes to small volume bladder cancers, this trimodal therapy is, it gives, there are certain studies to show that it gives equal results to radical cystectomy in the long run. But the carcinomas we see here in this part of the world are pretty advanced. And once it is proven that it is especially high grade or intermediate, high risk or intermediate risk, high grade or I think the trimodal therapy will be its take. That's my. So all depends on the volume of the tumor. I mean, you see a small volume tumor, though it is muscle invasive, you will go ahead with this trimodal therapy. I agree with that.
Trimodal therapy
and
anyway is not in the
yeah.
guidelines, sir. I mean, still
Yeah,
cystectomy
it
is the treatment. These are all
correct.
still at the trial level, but I'm just
Yes,
trying to tell these people for
you're
exam
right.
point
Yeah,
of view. Yeah, this
yeah,
is the new.
exactly. I think you should know what is which way we are moving. I think so. We must be very thankful to Srinath for sharing his knowledge in the Western world. Other thing is, yeah, that is one thing about this thing, and that open laparoscopic and robotics. If you compare it, is there any superiority in any of those? In comparative studies, is there any superiority of one technique over the other? I'm asking
No,
the
sir.
speaker.
There is,
Yeah.
when
Yeah.
compared to the cancer-specific data, there is no superiority, sir. But when comes to the minimal invasive benefits, they have minimal invasive benefits. That the surgical
Right.
time and the post-operative complications. Right. Yes.
One of the standard you mentioned about RACER study, is there any studies to compare open cystectomy with the minimal invasive techniques to show that it's done somewhere in 2016? You heard about Bolero study? Just read about it. Bolero study compare all three arms, randomized trial, all three arms compared, and there's no benefit on the outcome, final outcome. But the advantages of laparoscopy is there. So laparoscopy and robotics, you have to take it as, man with a hammer. Man with a hammer, everything will look like a nail. So I think the people who are doing laparoscopy and laparoscopic centers, everything will be done with laparoscopy or robotics. But when it comes to the practical side of it, you have to have superiority studies to show one technique is better than the other. These non-inferiority studies will just show that the technical advantages only. So if you are arguing, or if you are just arguing, just think of those points. And what about, can I ask a quick question about adjuvant therapy after cystectomy? Did you mention in detail, just a summary of adjuvant therapy?
If we give a neoadjuvant treatment, there is no added advantage.
Adjuvant. No,
Yeah,
I'm talking about adjuvant therapy, not neoadjuvant. That is after cystectomy. What sort of a treatment can you recommend?
We can offer again cisplatin-based therapies if we are not given.
So are you doing it routinely, or is it in selected patients?
In selected patients.
Yeah. What are the indications of adjuvant therapy, post-cystectomy adjuvant therapy, and what are the evidence? What evidence do you have? What is the first line adjuvant treatment after radical cystectomy in guidelines now, 2024? Is it chemotherapy?
It's chemotherapy.
Unfortunately not. First line treatment is what now? It's mostly immunotherapy. I don't know whether Srinath agrees with it.
Yes, sir.
But
Right.
they have all moved into immunotherapy and targeted therapy with immunotherapy. Yeah. Monoclonal antibody armed with drugs. So, nivolumab and then this new drug group. I don't know whether Srinath's
it's the PD-L1 inhibitors and
That's right. And also these monoclonal antibodies armed with these drugs also, I think, is coming up in a big way. Read about it. That is going to be the future, because now there are strong recommendations to show that that is the first line adjuvant therapy over the chemotherapy. So earlier it was BVP, platinum-based treatment, and now it is immunotherapy, which has shown better risk in the total outcome. And can I ask, what is the place of radiotherapy post-radical cystectomy? Is there a place for radiotherapy post-radical cystectomy?
Sorry.
Well, yes. Just read about the checkmate trials. I think that those are the radical cystectomy, nivolumab, and placebo comparative study. Just read about that. Radiotherapy, do we recommend radiotherapy, Srinath, in
No,
your setup?
not that I know of, sir. Not on the
Yeah,
top
I
of my
think there
head,
is a very
no.
limited, very limited place for it. Yeah. Anyway, so those are the comments I would like to make.
Thank you.
Is there another section in this program? This is the last.
No, sir, there
Another
are
speaker?
two more speakers are
Oh,
there. There is okay.
okay, better move on then.
We
Yeah.
will move on to
We'll
the
be taking
next.
the breakfast with you all. Yeah.
So next
Okay.
topic is metastatic bladder cancer. The speaker is Dr. Upul Indrajit.
Good evening to everybody. I'm Dr. Upul Indrajit, who's Senior Registrar Urology working in NHS here. My topic is management of metastatic bladder cancer. So I'll discuss about the metastatic bladder cancer, mainly the management part. So my presentation outlines are first I'll describe about the introduction, and then I will discuss about the evaluation of the distant metastasis in metastatic bladder cancer, and then I will discuss about the management of metastatic bladder cancer with regard to oncological management as well as the urological point of view management, and then ultimately at the end I will discuss about the supportive care of metastatic bladder cancer patient. With regard to introduction, approximately around 5% of the patients will present with the metastatic disease at the time of diagnosis. And common sites of metastasis are lung, liver, bone, and brain. Additionally, approximately half of all patients relapse after cystectomy, depending on the pathological state of the tumor and nodal state. From those, the local recurrence account for approximately around 10 to 30% of relapses, but distant metastasis is the most common cause of relapse. So with regard to evaluation of the distant metastasis, prior to any curative treatment, it is essential to evaluate the distant metastasis. Computed CT and MRI are the diagnostic techniques of choice to evaluate the metastasis, especially lung and liver metastasis. And apart from that, there's evidence for role of PET-CT for staging of distant metastasis, especially in the muscle invasive bladder cancer. In a recent series of 711 patients, there are PET-CT has shown to provide important staging information through the detection of distant metastasis, which may improve the overall clinical management of the patient. Apart from the evaluation, the bone and brain metastases are rare at the time of presentation of invasive bladder cancer. So there's low level of evidence to suggest that routine investigation for the bone and brain metastasis usually it's not usually needed. So regarding the studies, the recent retrospective study which chose a large number of patients, there's only 19 out of around 1,000 patients has shown bone metastasis. So and apart from brain imaging is also, as I mentioned previously, not routinely indicated unless the patient has specific symptoms or signs to suggest brain metastasis. So then I'll discuss about the management of metastatic bladder cancer. The main arm of management is the oncological management. So the treatment of metastatic urothelial cancer remain largely unchanged since early trials, which has published around 20 years ago, and it was in that since that age, usually first-line treatment was a cisplatin-based combination treatment, which has demonstrated significant overall survival benefit. But this long-standing paradigm was changed and challenged in the past years by the introduction of immunotherapy using checkpoint inhibitors. Since October 2023, with the presentation of a result of two practice changing randomized clinical trials. They have demonstrated overall survival benefit using this immunotherapy over the conventional platinum-based chemotherapy. The trials are the PV302, Keynote A39, and also the Checkmate 909 trials. So the result of these two trials change the first and later lines of management of patient with metastatic bladder cancer. So considering the first-line systemic therapy for metastatic disease, in generally, the patient with untreated metastatic urothelial cancer can be divided into two broad categories. One category is who are eligible for combination therapy. Other one is ineligible for combination therapy. So distinction between these two groups are currently based on the eligible criteria according to the EV 302 and Keynote 39 trial. And it mainly assesses the patient's fitness for the this oncological method of chemotherapy. So they'll assess patient's ECOG performance scale and GFR, and as well as the other functional organ functions assessment. So this chart will show the two groups which are platinum eligible and platinum ineligible patients. So the platinum eligible patients group has another two arms, which are cisplatin eligible and as well as the carboplatin eligible. So these platinum eligible patients are relatively fit patients, but platinum ineligible patients are very frail patients. So they are considered, as I mentioned previously, the ECOG status, GFR, and also the hearing loss rating, as well as the peripheral neuropathy and cardiac insufficiency. So most of these metastatic patients are very frail. So this grouping is important to categorize them and reduce their toxic profile when we are giving the the chemotherapy. So this chart will also demonstrate the oncological management part of this treatment of this patients with metastatic bladder cancer. Here, the first-line treatment also, as I mentioned previously, they have divided into platinum eligible and combination ineligible type. So then, according to that, the eligible patients, there are three arms which used for the enfortumab vedotin and pembrolizumab. These are the chemotherapy drugs which we are not usually familiar. So, and then then they are categorized according to the eligibility, and then very frail patients will go ahead with the either atezolizumab or pembrolizumab treatment, or the very the still unfit patient will go ahead with the best supportive care. So after that, they will go ahead with the later line treatment, and while treating, they will assess for the toxic profile, and with that, they will go ahead with later treatment. It's mainly these treatments are oncological management. I will mainly discuss about the urological point of management. So in urological point or the surgical point, there are mainly we have options for management. Options are the managing with all the metastatic oligometastatic disease, as well as the salvage cystectomy. So considering the metastatectomy for oligometastatic disease, it's in these patients are highly selected with oligometastatic disease who are without evidence of rapid progression may benefit from metastatic following response to systemic therapy. And there are very limited prospective data supporting the role of metastatic for treatment of urothelial bladder cancer. But there are several retrospective studies have demonstrated that metastatic can be a treatment option for certain patients with metastatic bladder cancer. The particularly those with favorable response to systemic therapy and patient with the solitary metastatic lesions, such as in the lung or lymph nodes, have shown some improved response. Regarding the evidence, there are a phase 2 trial of 11 patients with bladder primary urothelial carcinoma with metastasis to the retroperitoneal lymph nodes have shown improved survival benefit with the disease-free survival and relapse-free survival rates of 36 and 27%. And when considering the patient with viable tumor in no more than 2 lymph nodes and no excellent pre-surgical systemic chemotherapy, show the best survival rate, indicating low burden of disease or good response to pre-surgical chemotherapy is important in achieving benefit from metastasis. And another phase 2 trial of 70 patients who underwent complete surgical resection of bladder cancer metastasis investigate survival, performance status, and prolonged life following surgery. This study reported no survival advantage from surgical practice, but the quality of life and performance status were improved. And regarding the other option of surgical aspect is a palliative and salvage cystectomy. The unresectable, locally advanced tumor may accompanied by debilitating symptoms, including bleeding, dysuria, and urinary obstruction. These patients are considered as candidates for palliative treatment, such as palliative control of the system is palliative RT. RT control of the symptoms is not possible by less invasive methods. Patient may be offered a palliative cystectomy with urinary diversion or only urinary diversion only. Palliative cystectomy carries the greatest morbidity, particularly in patients with a poor performance status. In a series of 74 patients who underwent palliative cystectomy, severe complication occurred in 30% only. But when considered the mortality rate, the 30-day mortality rate was 9% in palliative cystectomy, and 8-month follow-up, there are 70% mortality rate. And in the supportive care, because of these patients, the metastatic bladder cancer patient, in considering supportive care, obstruction of the urinary tract is one of the most important aspect of managing. So unilateral or bilateral nephrostomy tube provide the easiest solution for upper urinary tract obstruction in these patients. And patients find putting the nephrostomy tube, this patient will find inconvenient and they will prefer the ureteral stenting. But however, with the stenting can be difficult to achieve because of the bladder tumor. So, and also other practice the stenting is the stents need to be regularly replaced. And there's risk of stent obstruction and displacement. Apart from for this patient, another possible solution is the urinary diversion with or without palliative cystectomy. Other supportive aspect is management of bleeding and pain. In case of bleeding, the patient must be screened for first screened for the coagulation disorders, or the patient's use of anticoagulant drugs must be reviewed. And transurethral coagulation may be difficult in these patients because the tumor is fully involved the bladder. Other option for the control of bleeding are the intravesical rinsing of the bladder with 1% silver nitrate or 1 to 2% alum. Can be used as an effective method, but and also this can usually be done without any anesthesia. The installation of formalin is a more aggressive and painful procedure which requires anesthesia, and also the formalin installation has higher risk of side effects such as bladder fibrosis. But it has high chance of control the bleeding. And vesicular reflux should be excluded to prevent renal complication when using this treatment. And apart from that, the managing the pain, also the radiation therapy is another common strategy to control bleeding in these patients, and also it will alleviate the pain of this patient. And older study reported control of hematuria in 59% patients and pain control in 73% when using the radiotherapy. Irritative bladder and bowel complaints due to the irradiation are possible, but usually mild. Non-conservative two options are for the control of bleeding are the embolization of specific arteries in the small pelvis with success rate as high as 90%. And radical surgery as palliative cystectomy is the last resort and includes cystectomy and diversion, and it has high morbidity as I mentioned previously. These are my reference, CAU guideline and NCCN guidelines. And thank you for listening.
Okay, thank you very much, Upul, for your nice presentation regarding metastatic bladder cancer. I think you touched all the aspect of management of metastatic bladder cancer. So we'll move on to quickly for the discussion.
I think, Upul, you did a very good job. You talked about a very oncological topic in a palatable manner. I think I don't have anything to add to this. In these kind of patients, always good to get the palliative team, because palliative medicine is also now picking up in Sri Lanka as well. Ideally speaking, they should have this palliative medicine medics also coming into the picture as well. Nephrostomy has always been a question, isn't it, Neville, sir, with regard to are we putting a nephrostomy or not in a patient who's on palliation? What are your thoughts on that?
Yeah, I think at once we were arguing long time ago whether you should allow him to go into uremia and die because it's all metastatic and then his lifespan is going to be short, or do urinary diversion, instead temporary urinary diversion by means of stenting. But unfortunately, stenting fails more often than not because the trigonal involvement and all this edema will prevent it from putting a retrograde stent. But it's always it's worthwhile asking the interventional radiologist to first put a PCN and allow the edema and everything to settle, and then try antegrade stenting. So that might work. But even if you can push the guide wire into the bladder, tiny 035 guide wire, then we might be able to dilate the ureter and stent it, and then we can put a silicone stent. It can last for about 1 year. Metal stents are not available here in our part of the world, but I think in specialized centers, the metal stents. But I think if the performance status is good and the patient is young and all these diversion technique fails, then some kind of urinary diversion, because uremic death is very sort of is unpleasant. So ethically, you are not supposed to let him go into uremia and die. Some people believed in my era that they should be just turned back to the palliative care. But I think the urinary diversion, at least one kidney, and then not allowing him to die of uremia. And other thing is that chemotherapy. They will not accept for chemotherapy if the serum creates are high, because platinum-based chemotherapy cannot be given. So by just relieving this one kidney or both, you might bring down the creatinine levels and then make him suitable for more chemotherapy, or now, of course, immunotherapy. So I think my idea is to treat uremia unless it's a moribund patient and you know that there is no life expectancy, so let him go. So that is my idea about obstructed systems. And the palliative cystectomy, I think up to T4A, that is involving the in a female uterus or the prostate, and not going into the lateral pelvic wall is feasible. But again, you have to tailor it according to the patient. I mean, if there is multiple metastases and the outcome is not going to be really good, I think I will not go for a palliative cystectomy. because as quite correctly mentioned, the morbidity and mortality are very high. Oligometastasis is a different ball game, and I usually don't come across very many people. Do you get them in that part of the world, or less than 3 metastases?
Yeah,
by the time they
very
come to us, liver is full of mets, lung is all mets, if it is a metastatic cancer. So,
yeah, metastatic bladder cancer, I think, is not much of a difference here as well. I mean, it's full-blown mets most of the time.
Yes. Yeah. So, but I think the strong evidence to show that this metastatic bladder cancer treatment has moved from chemotherapy to first-line treatment with antibody drug conjugate treatment. So that is the strong evidence now, EUA evidence this year. Enfortumab vedotin. I don't know whether you use it there. I think that's the first-line medication now they recommend. So better to read around that and see. That is a combination of ICI, that is all MABs are monoclonal antibodies tagged with this vedotin drug. So it's better to read about it because it has become the first-line treatment now. So
the regulations are not as tight as in UK, in European countries. So when a new drug comes, they straight away, I mean, that's why the evidence comes very early in Europe rather than in UK, because the FDA and the NICE approval basically takes long.
Correct.
So in a way, patients are disadvantaged.
The EV trial, that is this new drug Enfortumab trial, I think better for you to know about it. So that is one thing, but other things are comprehensively covered. Management, surgical management, but remembering all these MEBs and MEBs and MEBs, I think I'm happy that I'm not an oncologist. I can just palm off the thing to them to treat it and have various combination protocols. And no two oncologists are also same when it comes to these protocols. So, but the availability of drugs also matters a lot because these are expensive drugs now when it comes to ICIs and that is point inhibitors and things.
Okay, thank you, sir. So, let's move on to the next topic. We'll then move on to the last topic. It is about the upper tract urothelial cancer, which is done by Sanjeev, senior registrar. Over to you, Sanjeev.
Good evening, dear teachers and colleagues. So my topic is upper tract urothelial cell cancers. I'm Dr. V. Sanjeev. I will go through the epidemiology part first. It was previously first presenter, most of the facts, and upper urothelial carcinoma is only 5 to % of urothelial carcinoma, and the annual incidence is 2 cases per 100,000 inhabitants in the Western world, and peak incidence is 70 to 90 years, and the male-female ratio of 2:1. Approximately 2/3 of patients present muscle-invasive disease at the diagnosis. And pielocalcium tumors are approximately twice as common as ureteral tumors, and multifocal tumors are 10 to 20%, and concomitant carcinoma in situ is, and concurrent bladder carcinoma is 17%. And Asian patients present with more advanced and higher grade disease compared to other ethnic groups. Recurrence in the bladder occurs in 29% and 2 to 5% in the contralateral upper tract. Risk factors, this was previously discussed by the first presenter. Only the tobacco and aristocolic acid has a strong association with the factors. And there are other factors such as presence of arsenic, alcohol, and history of bladder carcinoma and hereditary upper tract urothelial cancers, which is associated with Lynch syndrome. Staging and grading, we use TNM classification of 2017. There is a TA, which is a non-invasive papillary carcinoma, and TIS, carcinoma in situ. T1, when it's invades the subepithelial connective tissue. T2 is invading muscularis. And T3, when the tumor is in renal pelvis, it's beyond muscularis into peripelvic fat or renal parenchyma. When it invades beyond the muscularis into the periureteric fat. And the T4 is tumor invades adjacent organs through the kidney into the perinephric fat. N1 is single lymph node 2 centimeter or less. N2 is single lymph node more than 2 centimeter or multiple lymph nodes. And tumor grading, the classification is 2022 as mentioned, WHO grading classification. Diagnosis can be symptomatic or incidental, but majority are symptomatic, 53%. Most common symptom is visible or non-visible, 70 to 80%. And they can also present with flank pain due to clot colic or tumor tissue obstruction. And systemic symptoms suggest metastatic spread, and we should investigate for that. And symptoms at diagnostic usually indicates a worse prognosis. Imaging, as previously mentioned, CT urography has the highest diagnostic accuracy and sensitivity with 92% and specificity 1%. But we can miss epithelial flat lesions without mass effect in the CT. MR urography is less with 75% for less than 2 centimeter lesions. So EAU recommends CT urography is more sensitive and specific for the diagnostic and staging of upper tract urothelial than MRI. Copy should be done to rule out concomitant blood. And the cytology markers useful when it indicates high lesions when the bladder cystoscopy is normal and in the absence of carcinoma in situ in the bladder and prostatic urethra. However, it's less sensitive for upper tract carcinoma than the bladder carcinoma, and voided urine cytology is less sensitive for upper tract carcinoma than the selectively obtained cytology of affected upper tract. We can use cytology or fluorescent in situ hybridization, which had comparable specificity and higher sensitivity than the cytology. However, both tests are suboptimal to rule out upper tract cancers. Diagnostic ureteroscopy, we can use URS. So when it's necessary to confirm the diagnosis of upper tract cancers or to suspicious lesions, and for tumor mapping before considering kidney sparing options, we can multifocality and size of the tumor, and also URS biopsy the tumor grade with higher accuracy. And ureteroscopy also facilitates the selective ureteral sampling for cytology. Studies found that URS with biopsy significantly increase the risk of subsequent recurrence. However, without an impact. However, so the EAU suggests the use of diagnostic uroscopy if imaging and voided urine cytology not sufficient for the diagnosis and or stratification of patients suspected cancers. Staging, approximately 9% of patients present with distant metastasis. CT is the diagnostic of choice for lung and abdominal staging, lung and abdominal. So it's a strong recommendation to perform CT abdomen, chest and pelvis in diagnosis and staging. Prognosis, there are patient-related factors and tumor-related factors. Patient-related factors, there are age, old age at the radical nephrectomy is associated with decreased specific smoking, similarly affect the outcome. And surgical, once the decision of radical nephrectomy has been made, the procedure should be carried out within 12 weeks, whenever it's possible. And high comorbidity and performance indices score, ASA, performance status, and Charlson Comorbidity Index also suggest worse prognosis. Tumor-related factors, tumor stage and grade are the indicators. So 5-year survival rate for non-muscle invasive is 86%, muscle invasive organ confined tumors 70%, and locally advanced tumors 44%. And multifocality, hydronephrosis size are all indicates poor prognosis. However, one feature alone doesn't indicate a high-risk disease. And pathological subtypes such as micropapillary, squamous, and sarcomeroid subtypes are also associated with worse outcome. And lymph node involvement indicates poor survival after surgery and lymph invasion and positive surgical margins. And other pathologies such as extensive tumor necrosis, sessile growth pattern, and concomitant in situ in organ confined upper tract cancers, and a history of carcinoma in situ, microscopic infiltration or invasion of peripelvic adipose tissue. So, clinical decision making, tumor stage is difficult to assess clinically. So, stratification system to classify the patients into low risk cancers and the high risk upper tract cancers. To be rendered as low risk upper tract cancers, the patient should fulfill all 5 criteria, which should be disease, tumor less than 2 centimeter, negative for high grade cytology, low grade URS biopsy, and no invasive aspect on CT. For high risk, there are strong criteria and weak criteria. Strong criteria, even one criteria render it as a high risk cancer, such as high grade cytology, high grade URS biopsy, local invasion on CT, histological subtype. Weak criteria, multifocal disease, tumor more than 2 centimeters, less, more or equal to 2 centimeter, or hydronephrosis are weak criteria, because if a low grade tumor with one of these criteria cannot be attributed to high risk, it should be decided on a case by case manner in a multidisciplinary meeting in deciding on treatment modality. In the prognosis, bladder recurrence is common. The rate of bladder recurrence after radical nephrourectomy is 22 to 40%. So there are 3 categories of predictors for increased risk of bladder. So patient-specific factors, male, previous bladder cancer, smoking, and preoperative chronic kidney disease, and tumor-specific factors such as positive preoperative urinary cytology, tumor grade, urothelial location, focality, tumor diameter, invasive stage, and necrosis, and treatment-specific factors such as use of diagnostic URS, laparoscopic approach, bladder cuff removal, and positive surgical margins. So, single dose of intravesical chemotherapy after diagnostic ureteroscopy of non-metastatic cancer has been suggested to lower the rate of intravesical recurrence, even though it's a low-level evidence. Previously, it was discussed. And discussed in 3 categories: localized low-risk cancer, localized high-risk cancer, and metastatic cancer. For localized low-risk cancer, kidney-sparing surgery is the primary treatment modality. It's a strong recommendation in the because it's reduced morbidity associated with radical nephrourectomy because of the loss of kidney function without compromising the oncological outcomes. So options for kidney sparing surgery is endoscopic ablation, percutaneous management, and segmental ureter resection. Endoscopic ablation can use a flexible ureteroscopic ablation in the management of pelvic calcium tumors. It requires early second look URS and stringent surveillance. It has a comparable survival outcomes to radical nephrourectomy at the cost of higher local recurrence and repeated interventions. Percutaneous management, it can be considered for low risk upper tract lesions in the renal pelvis, and also for the low calcium tumors that are inaccessible to flexible URS. However, it has the risk of tumor seeding along the tract. Segmental ureteral resection, it usually done for the ureteral lesions. However, upper 2/3 has associated with higher failure rates than for the distal ureter. For distal ureter lesions, we can do distal ureterotomy with ureteroneocystostomy. And with the kidney sparing surgery, the recent evidence suggests that the early single adjuvant intracavitary upper tract instillation of mitomycin C with upper tract cancer might reduce the risk of local recurrence. Before doing the intracavitary upper tract instillation, retrograde pyelography are recommended to exclude a contrast extravasation or obstruction. Localized high-risk disease. Nephrectomy with bladder cuff excision is the standard treatment of high-risk upper tract cancers. Open laparoscopic and robo-assisted approaches are similar for organ-confined upper tract cancers. Level of evidence is 2A. Several precautions can lower the risk of tumor spillage in minimally invasive radiconephrourectomy. Avoid entering into the urinary tract except when performing the bladder cuff excision and only after prior clipping of the ureter and complete drainage of the bladder. Avoid direct contact between the instrument and the tumor. Perform the procedure in a closed system. Avoid morcellation of the tumor and use an endo bag for tumor extraction. And the kidney and ureter must be removed en bloc with the bladder cuff. In invasive or large T3, T4, endo and node positive metastasis positive tumors, an open approach is favored as the oncological outcomes may be better compared to minimally invasive radical nephrourectomy. Lymph node dissection, it has proven that lymphadenectomy improves the survival in muscle invasive upper tract cancers. However, it is unnecessary in cases of TA and T1 upper tract cancers because of the low risk of lymph node metastasis. However, tumor staging is inaccurate in preoperatively. So, therefore, template-based lymph node dissection should be offered to all patients who are scheduled for radical nephrourectomy for high-risk upper tract cancer. Failure to remove completely the bladder cuff increases the risk of bladder cancer recurrence. So the bladder cuff excision is preferred. Kidney sparing surgery in high-risk disease only considered in imperative indications such as solitary kidney, bilateral cancers, severe chronic kidney disease, or any other comorbidity compromising the use of because of the greater risk of progression with a direct impact on survival. Place for neoadjuvant chemotherapy. Primary advantage of neoadjuvant chemotherapy is the ability to give cisplatin-based regimens when the patient is still have the maximal renal function. Prospective studies have shown evidence of pathological downstaging and complete response rates at RNU. However, and the lower disease recurrence and mortality to RNU alone. However, the evidence that it's not recommended in there's no strong guidelines available now. Localized adjuvant therapy, single postoperative intravesical chemotherapy, mitomycin C, 2 to 10 days after surgery reduces tumor recurrence. And postoperative platinum-based adjuvant chemotherapy improves the disease-free survival. We can use gemcitabine in combination or gemcitabine carboplatin regime. It has proven that an improvement in disease-free survival in patients with pathological T2 to T or any node, not with any T stage upper tract cancer. The main potential limitation is the concern that renal function may deteriorate after the radical nephrectomy, precluding the cisplatin use. Immunotherapy, nivolumab, which is targeting the programmed dead cell pathway, it has proven that superior benefit for adjuvant platinum-based chemotherapy over immunotherapy in patients treated with upper tract cancers. So it is used only for patients unfit for who disliked platinum-based adjuvant chemotherapy for more than pathological T3 or not positive after RNU alone, or patients after neurotherapy pathological T2 or N positive disease. This is a flow chart which is previously described for upper tract cancer management. And this is the flowchart for location and the preferred surgical options for upper tract management, which is previously discussed. And I'll move on to metastatic disease. So initially I'll talk about the lymph node metastasis. So patients with clinically not positive upper tract cancers should be offered downstaging first-line platinum-based chemotherapy. So depending on the extent of the nodal disease, whether it's clinically N1 or N2, surgical resection with lymph node dissection can be team with the patient when responding on after the initial systemic therapy. And after that, if the patient is responding, we can continue with maintenance avelumab monoclonal antibody, which can be offered in specifically N2 disease. And if still cancer progress with the first line chemotherapy, we proceed for the second line chemotherapy. Disease, now, as previously mentioned in the metastatic bladder cancer, the first line treatment has changed recently in 2023 after EV 302 phase 3 randomized multicenter study. So now the first line treatment is enfortumab vedotin in combination with pembrolizumab, which is a antibody drug conjugate with the monoclonal antibody. And if the patient is not eligible for this mode of therapy, then we can go for this platinum-based chemotherapy regimes. And this was previously discussed flow chart for the upper tract cancers also. For surgery for metastatic disease, radical nephrectomy is only in a palliation setting in symptomatic patients who has resectable disease, and there is no place for metastasectomy in upper tract cancers. Follow-up, more frequent and more stringent in patients who have undergone kidney sparing treatment, radical nephrectomy. After radical nephrectomy, if it is a low risk tumor, initially first cystoscopy at 3 months, and at 1 year, and yearly for 5 years. And high risk tumors, cystoscopy and urine cytology at 3 months. If negative, repeat every 3 monthly and every 6 months thereafter until 5 years, and then yearly. So have to combine imaging, CT urography and chest CT every 6 months yearly. And after kidney sparing management, low risk tumors, cystoscopy and CT urography at 3 to 6 months, and then yearly for 5 years. And we also have to do the URS at 3 months if second look ureteroscopy was not performed. High risk tumors, perform second look URS and cytology in 6 weeks. If no residual tumor, follow similar follow-up principles as for high risk disease treated with radical nephrourectomy. Thank you.
Thank you, Sanjeev, for that very informative presentation on upper tract cancers. And now it's time for few questions and discussion.
Sanjeev, a nice presentation. I think you covered everything. I don't have much to say. I think you include and another speaker mentioned alcohol consumption as a risk factor. I don't know. I've not come across that. No, I'm not a proponent of alcohol or anything like that, but I don't know whether it's a significant risk factors to mention. I don't know where you found it from, but I've been reading up recently, and I've not come tobacco definitely, but alcohol I don't know about. Best to avoid, I would say, in a public forum.
We can't hear you, sir.
Neville, sir, we can't hear you.
Sorry, I think I put mute, I think, yeah. Now let me see.
Yeah, we can hear you now.
You can hear? I went off.
Yes.
Yeah,
Zoom. Right, Zoom went off. Let's see. Okay. Yeah, I think Srinath is quite right. I think I was wondering, whether alcohol has anything to do with urothelial cancer. because there's one small study long time ago I read, and it is beneficial. So don't drink, but I'm also not a promoter. I'm a teetotaler. So anyway, just remember that when you mention it, people might start questioning. So I think, yes, as Srinath mentioned, I think you covered a fair bit, fairly nice presentation. So if you can summarize, so suppose now if I give you a little case, now how would you biopsy these tumors? Now, to classify it into high risk, low risk, and then to stage it, like bladder cancer, of course, you can always resect it and get the depth and everything. So, urotic cancers, how do you biopsy? And urothelial cancers.
So with the flexible URS, I can visualize and take representative biopsies.
Right. You think that you can take the bladder, the wall as well without perforating? Because you don't have that same benefit of having a thick wall in the ureter. So I think the pathologist will most of the time will say that yes, it is TCC, but muscle is not included. So how do you know that this is muscle invasive when it is T2 or more? Here, of course, you have to heavily depend on this MRI or CT imaging, yes, CT and MRI to find the depth of the tissue, because biopsies generally will not be very helpful. So that is one thing. And then if I just to summarize this, this time, and suppose you see a large volume tumor in the renal pelvis, okay, and MRI says it's confined to the renal pelvis, and then there is another tumor halfway through in the ureter. Again, the MRI will say that probably muscle invasive. Just summarize in point form, how do you manage this patient? What will you do to this patient? Is a good performance test. This performance test is good. He's in his 60s, let us say. So unilateral tumor. Can you just outline in 2 minutes or 3 minutes, 2 minutes? Because everybody is sleepy, I suppose. Half of the audience must be, feeling really tired now. 3 minutes, just outline how would you manage this patient?
So first I'll stage the disease with the it's only the two focus of, and I will stage for the distant metastasis, and then I will assess the renal functions.
What will you do exactly for the distant metastasis?
CT chest abdomen.
Vague answers, yeah, okay.
CT chest abdominal list metastatic, and then I will assess the renal function with serum creatinine. And with that, I will go for a multidisciplinary meeting to decide on whether to go for. It seems to be a high risk disease.
What will be your opinion in that multidisciplinary team? This is MDT meeting is something to hide behind all candidates, but I think you should give your opinion about what you are going to do or you are going to argue for in the multidisciplinary team meeting. It's always nice to mention that. What will you do as a surgeon?
Renal functions are normal, sir. This patient will benefit from a radical nephroureterectomy.
Okay. So you won't consider any minimal invasive techniques?
Since it's a high-risk disease, sir, so I will consider radical nephroureterectomy as the first option.
Right. Okay. Right. So go ahead. Will you stop at that, or will that be the end of the story for this patient? So, what is your idea? In MDT, how will you argue for go against it? Will you give neoadjuvant therapy for this patient?
That will depend on if the patient has any lymph node metastasis, then I can opt for neoadjuvant chemotherapy, sir.
All right.
If not, then I will directly go for upfront surgeries.
Right. Okay. Then, is it going to be surgery alone, or are you going to? What about adjuvant therapy? You're discussing cancer treatment, always give the place of neoadjuvant and adjuvant chemotherapy or radiotherapy.
Adjuvant therapy, we will give intravesical mitomycin C instillation after 2 to 10 days. And then
yes.
It's a high risk disease. So I will
any studies supporting that? Any studies supporting these adjuvant intravesical chemotherapy? Is it going to be every patient or not? Yeah, read about ODMIT trial. ODMIT trial. Okay. Yeah. ODMIT trial, and that proves that it is beneficial. So always you will consider it, as Srinath mentioned quite correctly, not immediately. Any infection, hematuria, or any kind of bladder surface injury, you don't put immediate intravesical chemotherapy. Okay, it's contraindicated. Good. Then, any place for adjuvant chemotherapy?
Adjuvant, the recent studies has enfortumab vedotin and pembrolizumab combination therapy is a first line chemotherapy.
So everybody you will recommend this treatment?
No,
everybody
sir.
after
For this patient, we'll go for a platinum based combination therapy.
Why is that? If that is the first line recommendation, why are you going for okay, so will you do a lymph node dissection as well?
Yes, sir. I'll do a lymph node dissection.
Routinely, will you do a? Yeah.
Because it's a muscle invasive disease. And depending on the T stage, we'll decide on the lymph node dissections.
Right. I think there was a question. No, Milan, just see regarding the contralateral kidney. It just disappeared. How do you follow up the contralateral kidney? Something like that. Somebody has asked a question. All right. I think that's I think concludes it. My comments.
Yeah. Yes, Sanjeev, I think, I mean, that's a good scenario that Neville sir basically gave. You know the answer. I would say this, just talk confidently. I mean, that's the only thing. And when you asked a question, MDT, yes, you have to mention that. You have to say MDT, and I would most likely, this patient most likely would require so and so and so straight away. I mean, you may be wrong, I mean, that's fine. You are going to just give an answer. I mean, rather than saying, I'm just waiting for the MDT to make a decision. I mean, just go for it. That's what I would probably say. Exam wise, Viva should be approached in that way. But,
Sir, I have a doubt. Hello?
Yeah, I can hear you.
Yeah. In a patient with polypoidal lesion in the distal ureter, when we do a ureteroscopy and biopsy, it has come as a pun lump. And they have, because only polyp, and we have completely excised that polyp. So my question is, because biopsy can be understaging, so are we going to go for follow-up for surveillance, or is there any place for segmental resection in pun lump?
I don't know, sir, what you think, sir. But my impression is pun lump is still, it's not considered as a cancer as such. It's basically
So we can go for surveillance if there's a residual, because if there's residual tumor left behind, then we have to go for the minimally invasive surgery. Otherwise, we can
probably do a repeat URS, I would say, to see if there's a lesion, or imaging. Imaging, I would be ideal, I would say. CT urography would be, I mean, you don't need an MRI for that.
Yeah.
And if you are reliably taking it out.
Yeah, I agree with Rinath in that sense, because if it comes as pun lump, I think that shows, I think even what we call papilloma in the past, I think is included in that. So straight away going for invasive treatment is, you can probably postpone, but I think you have to keep that ureter under surveillance and a ureteroscopy, diagnostic ureteroscopy after a few weeks. I think don't delay too much. As soon as the now if you use laser to resect it, the laser effect or the URBT effect, as soon as it goes off, I think you should do a imaging followed by a ureteroscopy.
Okay, sir. Thank you.
With the first recurrence or first suspicious biopsy, I think you go for a segmental ureterectomy.
Thank you, sir.
Okay. Yeah, I think I might have to leave, but before that, could I make a few comments on these all the speakers? You did an excellent job, but I think as Srinath and I agree, and also should I agree that going through these diagnostic charts and giving the lecture out of the textbook is not that difficult. You can study and do that, but applying that to a clinical scenario is something you have to practice. So I think always get a clinical scenario as soon as you have prepared this lecture, get a couple of clinical scenarios, and then see what you are going to say if this is a patient. So get various like metastatic disease, what will I do? So apply all that knowledge you have mentioned, outline there to a clinical case scenario. Otherwise, the Viva, we don't know what sort of a case we will prepare. So that will be difficult. You may be fully knowledgeable, but might not be applying it properly. So do that. And also, I would give a slight advice that the speakers in future, I might not be in the panel, but talk to each other, and there's a fair bit of repetition. Like, classifications and, TNM classification, those things and risk factors and things like that. It's like a common topic. See whether you all can have a little chat and say that, okay, I will tell about the risk factors. If those are same for the other, just drop that and speak more on management. So that is it. And just a little point about the guidelines given in guidelines. If suppose you are not practicing intravesical chemotherapy, immediate intravesical chemotherapy within 6 hours, is there any other way they recommend in these new guidelines to avoid, to prevent recurrence or reduce the chance of recurrence? They have given it as a separate guideline, which we do all these years without our knowledge. Has anybody come through that? There's a strong guideline to show that if you are not doing intravesical chemotherapy, do bladder lavage. You bladder wash out. However sure you are that your TURBT is quite good, and do it for about, say, a few hours. And that bladder lavage also has been shown now on evidence that it will reduce the chance of local recurrence in non-muscle invasive bladder cancers. That is given in new guidelines.
So what kind of
I think that is
bladder
just a practical point. Yeah. Yeah. Right. So
Yes, Sanjay, you were saying something.
Sorry, yeah, somebody was telling something.
Sanjay.
No, I'm asking what kind of bladder lavage you recommend, I think.
Yeah, this we are blood irrigation, no? I mean, sometimes we are pretty sure that this is a dry TURBT, but then you just stop it after 1 or 2 hours. But if you continue it for a few hours, I mean, unless you do it as a day case, I mean, that also can have similar effect as mitomycin C given within the 6 hours. So just read around that, and there is evidence coming up.
So it should be a water irrigation or the saline irrigation.
Yeah. Water, saline, it doesn't matter really. It is just, the TURBT is called urological madness. That's why this en-bloc resection has come to the scene. Madness because all the other tumors are taken out with the capsule and the perirenal fat and everything. You don't even see the tumor. Here we cut and chop it into pieces, and all these little pieces get deposited in the trigone and the bladder base while we are doing it. And they have an affinity to get attached to it. That's why the recurrences are highest in the bladder base and trigone area, considering the position of the patient. So to prevent that only, you put this MMC, and this bladder lavage or bladder irrigation will achieve the more or less the same outcome. So evidence is gathering. So just read about it. So
And the other thing that I want to, just one thing to add, I don't know, sir. I mean, in Kandy, as far as I can remember, BCG was not given in the urology wards. It's basically under the oncologist, and in Gampa also it was the same. So, but BCG is urology. Simply speaking, at least, I mean, UK and any exam worldwide. So you need to know in and out about BCG, the side effects, contraindications. I mean, what to advise to the patient, how it is given, what's the dose of it. You need to, I mean, everything needs to be known. I'm not talking about the regime and things like that, the LAMPS regime and things like that. Yes, you need to know, but the general, because in the Vivas, they basically expect, I mean, the practical aspects, you know, I mean, what would you tell the patient, you know, how is it given, and what sort of precautions you need to, or the nurse needs to adhere to. Those things are quite important. And same with mitomycin. I think mitomycin is given in some places in urology.
Yeah, mitomycin. Yeah. Yeah, I think that Sohan knows the struggle we had to give mitomycin C. I think we faced with so much of resistance, and all the nurses were thinking that they are not going to be pregnant thereafter, you know, if you put mitomycin C into the bladders of the patient. So I think that came to a standstill, and we hit a black ball, and not to mention BCG. So BCG, even BCG, I think still we are sending them to Maharagama, and the oncologists are doing it. So though it belongs to us really, we don't have the setup, even in Colombo. So I think, as we have quite correctly said, everything about BC should be known. And also the scarcity of BCG supplies, which comes on and off in I mean, universally it is there. The reason, and then connote the strain and the strains of BCG. And so all the studies, better to know. Yeah.
There's a scarcity in UK as well, just to let you know, sir.
That's the thing, really. It's a
so that's why there's this
scarcity.
Big discussion whether we need to give 3 years or just stop it in 1 year, you know, because there is a shortage.
Yes, that's right. Yes.
All right.
So,
okay, thank you very much.
We conclude
okay, thank you very much. I think we have come to the end of this discussion. So I have to thank first SLAU's president and the secretary, and then the CIPLA for providing this platform to do this kind of presentation and discussion. And today's 5 speakers, including Dr. Tirika and Pragladan, Madhushankar, Upul, and Sanjeev, you have done the very good, excellent presentation. And then today's expert panel, Dr. Sohan sir and Dr. Srinath sir, and the Neville sir and Anuruddha sir. So thank you very much for your contribution and updating us with the new guideline and the new coming things to in managing the urothelial cancer. So thank you very much, and good night.
Thank you very much. Good night, everybody.
Good night,
Good night.
Good night, everyone.